Hello, I'm Dr. John Kruse, and today is a question and answer ADHD and other mental health session for up to an hour. As usual, I will start with a recap of the three 1-minute videos that were released this week. Two were re-recorded, one was a brand new video, and then we'll launch into the Q&A. And the Q&A can be on these topics, it can be on any ADHD topic, it can be other broader mental health topics, and I will try to be candid if I don't know the answer. I will also try to smile more since I've been told I should do that. So the three videos, one was on video games and ADHD. That was a video I made in 2020. It was a few months after Endeavor RX was released. That was the first time the FDA had ever approved a video game for treating any condition, and it was for treating ADHD. The program was designed by neuroscientists who've been heavily involved in research in ADHD and other neuroscience areas. And things to be aware of is that medications undergo a much more thorough review by the FDA than do devices or products. So this isn't saying this is equivalent to a medication. I have not checked back on so it's now 4.5 years plus since it was released, whether they've done follow-up studies. One of the big questions is there are measurable short-term benefits from this multiplayer game. The question is, are they really persistent and do they really carry over to daily life? And so far, I'm not aware of data that they do. I'm not aware of data that they don't, but clearly short-term effects can be positive. Second video that was re-released was on anxiety and ADHD. The two have a complicated relationship. So one, there's a host of symptoms that overlap. Forgetfulness, distractibility, troubles concentrating, fidgety restlessness, even forms of impulsivity are common in both conditions. And it's clear that in childhood, having ADHD actually predisposes to later development of an anxiety disorder. The thought is that if you're missing information, if you're blurting things out, if you're getting into social difficulties or trouble or challenges, you may start to doubt yourself or question what you're missing or forgetting or not tracking properly. And in terms of treatment, paradoxically, even though the stimulants often increase anxiety in those without ADHD, they can, doesn't mean they always, decrease anxiety in the setting of ADHD, and other medications can be used as well. And then the third topic, and this was a general mental health, not ADHD specific, was about transgender health and specifically looking at changes in transgender care and societal attitudes in the last 25 years. 25 years ago, at the turn of the millennium, very, very few individuals were out who were transgender, and they were treated pretty much as extreme, I'll just say, freaks. Now there's much greater visibility, not just of transgender, but across the whole LGBTQ spectrum. And along with greater visibility, there's lots of backlash. And a lot of the backlash claims that treatment or approaches are purely experimental, or they're inhumane, or they're butchery, or they're untested. There was a big review done by a pediatrician, blanking on her first name, Cass is her last name, requisitioned by the British National Public Health Service because gender services across the Western world have surged in demand. More people are seeking assistance. And that does not mean that it's only a minority of these individuals who are seeking assistance with either medication, hormones, or surgery to change their gender. Many of them are just seeking ways to accept themselves or to understand themselves. Anyway, the critics claim there isn't much data. There are actually several thousand published research articles on transgender treatment confirming that it is beneficial for mental health and beneficial for people's acceptance in the world, and not terribly high rates of problematic side effects. So Not that they're free of those, but we can get into that if anyone wants to. So those were the 3 videos. One last test, the subreddit under Dr. John Kruse, DrJohnKruse, is up and working. If that turns out to be a good place to exchange comments or questions, we will see. And I already saw Dennis. Hello, Dennis. Started out with a good question, and I will have a lengthy answer to that. So Dennis's question is, he heard that benzodiazepines lose their hypnotic effect over time, but their anxiolytic effect is maintained. Is that true? So that question is good because there's so many different levels to it to address. One is that throughout psychiatry, not just ADHD or anxiety or medications, we have really lousy measures for whether people are obtaining benefit or whether drugs are working. This is not to belittle lots of very brilliant people who spent their whole lives figuring out ways to measure this, but whether I think a lot of the confusion and misinformation about antidepressants don't really work comes from comes from our studies not being able to show it as clearly as it shows up in people's lives. So one issue is we have poor ways of detecting how well or how poorly either sleep benefits or anxiolytic benefits are maintained. I think most of the studies that have done and most of the clinical experience suggests 2 different things and conflicting things. One is that there is some initial benefit from benzodiazepines, either for anxiety or from sleep benefits, that is diminished substantially with time. And yet, so tolerance to both of those effects is possible and probably common. And yet, many people, large numbers, keep persisting in using these long term, even if they are less effective because their own subjective experience, which I think has at least some validity, is that they are at least working partly. Now, a really big confounding factor with this is that with anything that, so if this is your anxiety level, any agent that acutely drops your anxiety, excuse me, any drug, any agent that's acutely dropping your anxiety and dropping it for some period of time, then wears off. When it wears off completely, it doesn't leave your anxiety at that constant baseline. It shoots you up to a rebound increase in anxiety. Now, the increase in anxiety is not as large in magnitude as the benefit most people get initially. But on the other hand, the duration, the half-life of withdrawal periods is usually 3 or 4 times longer. So for an example, benzodiazepine like Xanax that helps with anxiety for an hour or 2, when it wears off, is going to leave you somewhere 4 to 6 hours at a slightly higher rate of anxiety. And what's important about that is if you take another Xanax during that period, you're treating both the withdrawal and you're treating the extent actual non-withdrawal anxiety is related in there. So that makes the benzodiazepines pretty hard or tricky drugs to stop using because of the rebound effects. And there's rebound effects for insomnia as well as for anxiety. So the fact that efficacy seems to diminish at least somewhat for most people, and yet many people want to continue using them, it's hard to discern whether they're really continuing to get some genuine benefit. I believe they probably do, or whether it's largely that getting off of it reminds them of where they were before they started and makes it hard to stop getting it. So that's, and I would say it's not particularly with sleep. Most of our classes of medications for sleep, so the barbiturates that were used before the benzodiazepines, drugs like Restoril, Halcyon, and then the Z agents, which are not structurally benzodiazepines, but bind to one of the benzodiazepine receptors. So Ambien, which is Zolpidem, Zopiclone, which is Lunesta, and I'm blanking on Sonata's Z name, Zaloplan. So all of these drugs, as well as trazodone, which is used for sleep, or Doxepin, a tricyclic, or The mainstay in hospitals when I was in training before Ambien was released or became popular was Benadryl, which is an antihistamine. All these drugs, the longer you use them, the less effective they appear to be. Whether that's true, so all these drugs are sedating drugs that work on the sleep system to make you sleep harder, as it were, and yet most people with insomnia don't have problems with the sleep system. They have problems with not shutting off daytime arousal systems. So drugs like Belsomra, which is a dual orexin agonist, I'm blinking, blocking agent, shutting off the arousal system, whether the effects of those agents or of Rosarum Rameltion, which is working primarily as a signaling for the onset of sleep rather than a sedating effect, whether they diminish as much in their benefits over time is not as clear. But all of this aside, there's pretty compelling, extensive evidence that cognitive behavioral therapies are a better choice for most people, particularly for chronic insomnia. And these train people on how to shut off arousal, how to prepare themselves to sleep, how to set up the good conditions for sleep, and remembering that it's not just duration of sleep, it's the quality of sleep, which involves getting sleep at the same time each night. So probably over answered your question there, Dennis, but thanks, it's a good one. So hello, Jonathan Carpenter. I'm fine today. So Max is bringing up the UK CAS report. You mentioned that the criticism could be dismissive. Could you expand on that? So the CAS rate, so again, rates of people seeking care regarding gender issues have gone up dramatically. Again, this includes people who are lesbian, who are gay, who are uncertain about their identity, who are non-binary, who are transgender, and I can go back and try to define any of these terms if you want. Transgender, by definition, is people who are assigned one gender. So gender has to do with sexual identity, how you see yourself and feel yourself to be. It is not, most people don't have to think about what they feel, including most cis individuals. So it's a useful tool to ask them, well, when did you decide to be male? And they'll say, well, it's not a choice. And similarly, many individuals who identify as transgender do not identify or feel it's a choice. They were assigned a gender different. So gender is different than sex. Sex refers to the biological attributes of maleness or femaleness or something else. And one of the things, and President Trump just on his first day in office signed some patently false and stupid declaration that there are only two sexes. That's a meaningless claim because we know that whether you define sex by genitalia or by chromosomes or by hormonal levels or by certain structures in the brain, many people are concordant for all those, but we know that a small percentage of people will have chromosomes that suggest one thing and external genitalia that's another, or hormonal levels that represent something. And so the claim that there are only two sexes even is not supported by evidence. So anyway, the CAS report was a response to a surge in people seeking resources, and particularly that because of so much of a demand, and it's a public health system with there's some health care outside of the system as well, but most people got much of their care through the public health system, that there were increasingly long waiting times, and particularly for some children who were in distress about their assigned gender, that long delays were probably definitely measurably increasing mental health problems associated with this. And what can we do about it? So the so she was a pediatrician. She didn't have particular expertise in transgender or gender affirmative approaches, but did a thorough evaluation of the existing research and conferred extensively with all sides of the story. So not just patients, but also clinicians and researchers who are doing gender affirmative therapy, as well as groups who are completely opposed to any recognition that there is anything other than two sexes. And she tried to write a very balanced, inclusive report. But one of the summaries of a report, just looking at it, is she comes across as fairly dismissive that this is a new field and there's not a lot of research. And that could be said about any new field of research. And then some of the problems, some of the other problems with the report were that she, as the critics do, focus on that there's of people who are who receive puberty blockers. So these are young kids who have not yet entered puberty fully, and puberty blockers, the claim are given to kids. Given to block puberty. These have a good track record in people who have endocrinological chromosomal problems that interfere with normal gender development and puberty. So anyway, these drugs have a good track record outside of the transgender field. The context that she writes about, or she summarizes, is that there's a really high rate of people who start on puberty blockers who then go on to transgender surgeries or other hormonal treatments, male hormones, testosterone-based products for people who identify as male and female, and or estrogen and progesterone approaches to people who identify as female, and presented it instead that the purpose of puberty blockers is to give kids more time to decide, and therefore there's something wrong if 80-90% of people on puberty blockers go on to actually want to change their assigned gender. But that's actually a misunderstanding of the purpose. The purpose isn't just to delay or buy time, it's primarily to block the development of undesirable physical attributes of the gender you do not identify with. And the fact that there's a high percentage of people who go on from gender puberty blockers to gender reassignment shows that rather the group of individuals, who is a small percentage at any gender clinic that's been studied, who do go on to choosing puberty blockers, that they've been well vetted and that they are firmly committed and have shown extensive identification with the gender that they are identifying with, and that therefore it is appropriate that most of them do go on along this pathway. It's not a problem. Other critics have focused on a handful of individuals who have detransitioned, who went through this process and then later in life, usually as young adults, decide, no, I am really now identifying with the gender I was assigned at birth, not the one I transitioned into. And some have even gone through some attempts to detransition, either hormonally or surgically. There are a few of these cases, despite the best efforts of the communities who are opposing all such treatments. They have not been able to drum up, and they are very actively recruiting. They haven't found more than a handful of examples. These people's lives are tragic. I don't want to trivialize that. I don't disagree that some of them may have gotten inadequate evaluation or guidance or over guidance or help, pushed in one direction. But to claim that's the main thing that's happening at these gender clinics is just unsubstantiated by any survey or information. So most gender clinics suggest publish findings that success in terms of satisfaction, and this is of people who are transitioning, rates of success are in the 80 to 90%, and that's including just appearances, when many people in the world today aren't satisfied with their appearance. And if you look at something like knee replacement surgery in the US, where close to 1 million, it's a little several 100,000 are done a year, orders of magnitude more than transgender surgery, rates of success assessed by patients' assessment of pain and dysfunction are actually a little below the success rates of transgender surgery. So I'll stop there unless there's specific questions. But again, the claim that we have not much research, there actually again there are thousands of studies that have been done, and there's particularly a lot of research showing establishing laws that discriminate against transgender or LGBT kids in general measurably increases rates of negativity, depression, suicidality, substance abuse in those targeted populations. So jumping to a completely different topic, Richard asks how to increase blood flow to the brain. And my simplistic answer to that is sort of the ancient Greeks' maxim of a healthy brain and a healthy body, that the better your physical health and conditioning, the better that is. Your brain is a real organ with a blood supply, a lymphatic supply, flushing out garbage. The healthier your body is, the better your brain flow. So some amount of vigorous aerobic exercise a few times a week, and avoiding morbid obesity, which we know presence of fat cells is a cause of excess inflammatory chemicals throughout the body, including the brain. So I'd say exercise and general health would be the best answers that I can come up with. So Max is forwarding a question from the subreddit from Cranberry Funny, which says, could learning a new language help to strengthen Broca's area? So I don't know the simple answer to that question. Again, the area, and I do have a video on this, is whether learning a second language helps prevent dementia and or has other benefits. And it's pretty clear that people who are bilingual do have more redundant pathways and more cognitive reserve, so that when something like dementia develops in these individuals, and this is oversimplified and crude, but more of their brain has to be rotted away before they are at the same level of dysfunction as a monopolar. How much of that involves Broca's area, again, this would actually argue it's much more diffuse networks and areas of the brain that are involved in. So learning a second language isn't just learning all the content, the syntax, the grammar, the social idioms, the context of that language. You also have to know when to suppress your native language and use the other language. So there's more use of executive functions in terms of turning one thing off, repressing, inhibiting, holding back another thing. It's balancing two reservoirs of information, as it were, two systems. So again, in addition to just the intrinsic things you're learning with that second language, it's the balancing between the two that might be at least as important. It says he uses mirtazapine, which is Remeron, for insomnia, and it's been effective. He has ADHD and always struggled in general with intrusive thoughts when I'm not busy doing something that I enjoy. So mirtazapine is a antidepressant that's in a class by itself. It indirectly boosts serotonin and norepinephrine. It's not a direct, strong reuptake inhibitor. And its two common side effects are to be sedating and to increase appetite and weight gain. The appetite weight gain only affects about 20% of people, that's still a considerable percentage, and it can often be irresistible. The sedating effects tend to be universal, and about 15 to 20% of people initially are sedated. So it's usually a bedtime medication. Some people do feel tired, groggy throughout the day. And in my clinical experience, if that doesn't go away by the end of the first week, that may be a persistent effect and usually mean it's not a good fit. Much more often, the sedation is happening or constrained in the nighttime, and it makes, um, again, a useful tool for people who have trouble with sleep. What, yeah, that's so I'm glad it's helping. So Max is sharing that, and I don't even know how they pronounce it, Quivic, which is daridorexant, which is a dual orexin receptor antagonist, shutting off the daytime arousal system. So the other drugs in that group are Belsomra, which is suvorexant, and lemborexant, which is Davigo. They're newer agents. Again, most agents push harder on sleep. They increase the sleep, which isn't the broken part of the system. The broken part of the system is daytime arousal is not shutting off. These are directly shutting off daytime arousal. And in general, drugs that help you sleep better at night tend to help people be more alert during the daytime. So I'm glad it's helping. And I think so far the evidence, and again, these are newer drugs, they're expensive drugs because they're still, at least in the US, on patent. And furthermore, most people who have used a sleep agent are used to being sedated. They want to be knocked out. They're feeling, I can't turn off my brain. I need to be knocked out. These drugs do not knock someone out. They again cut off daytime activation and make it easier for sleep to arrive. But if you're used to having a knockout effect or depending on it, then people try these a few nights and say, it didn't do any good. It didn't put me to sleep. So particularly across the first 2 or 3 weeks, there's evidence that unlike almost all the other drugs, which actually are losing their efficacy to some extent that quickly, some of it anyway, that Belsomra, and I think there is some evidence for Xerum too, which is a different mechanism of action, are more effective at the end of the first week than at night one, and more effective at night at the end of the second or third week than they were at the first week. So these, at least in the short term, seem to improve their efficacy. And the longer term data, it's not a lot has been done. So Mokhtar Swat asks, at what dose did duloxetine start to be helpful for ADHD? So duloxetine Cymbalta is a dual-acting serotonin norepinephrine reuptake inhibitor. It's considered fairly evenly balanced. It is stronger on serotonin, but the lowest dose, 30 milligrams, is having some significant norepinephrine reuptake action that's probably at least as robust as Strattera's at a roughly equivalent dose. So it is having some effect at the lowest doses. That's a big contrast to Effexor venlafaxine, which is also a dual-acting agent, but is at least 10 times stronger on serotonin than on norepinephrine. And until with Effexor, you're getting above 100 milligrams a day in most laboratory situations, you're not doing much at all on the norepinephrine end of things. So I've seen people who perceived immediate ADHD benefits from doses as low as 30 of Cymbalta duloxetine. More often, the people I've worked with are anywhere from 60 to 120, which is the upper limit approved by the FDA for depression and anxiety and chronic pain. And many of those people do notice incremental differences going from 30 to 60 to 90 to 20 of more improvement in help with basic executive functions across that dosage range. So Bob asks, is there any research on anabolic steroids helping with ADHD, possibly with rejection sensitivity dysphoria, and in general with ADHD, dopamine regulation, and depression? So, and I have a video on this. There is some evidence that, at least in some individuals, testosterone can be a potent benefit for ADHD symptoms. And at least in a handful of individuals, it seems as potent as stimulant medication. Who those individuals are or why this is, how generalizable this has not been systemically demonstrated. When I've talked with patients, many who are on males identified at birth on testosterone because of prostate surgery and prostate surgery treatment. And again, many of these were not even necessarily with ADHD themselves, but I'd say the majority of patients did not notice any marked impact on their executive functions being on testosterone, but a few do. So I'm not aware of any research actually looking at anabolic steroids. There may be, but other than testosterone, so I don't know what's been looked at. In the literature, I mean, anabolic steroids can help people feel more powerful. I mean, certainly if they're resulting in changes in your body and you're accompanying it with exercise as well, they can theoretically result in more positive self-image. That could help with rejection sensitivity dysphoria. Theoretically, I don't know any, again, studies showing it. And the downside is that there are certainly some people who are more volatile, more aggressive, more, and some who develop what look like frank, florid manic symptoms or even psychosis with anabolic steroids. So, second, I mean, connected with that is if it's not coming from a, and big pharma isn't always the evil villain, but if it's not coming from an established pharmaceutical source, you may not even know exactly what you are getting in your anabolic steroids. So often, muscle building regimens have been found to contain stimulants, so that help people exercise more aggressively, maybe. And I'm not saying they're only containing stimulants, but that those are added on. So there's the potential for lots of contamination and lack of clarity as to what someone's really getting. Um, so that's, I guess, about. Yeah, so Bob is asking or furthering if someone is already in the high range of natural testosterone levels. So to some extent, taking testosterone when your body's normally producing it, some of what it does is there are feedback loops with testosterone. Back to FS8 follicles, pituitary hormones that regulate testosterone production. So taking more from an external source, often all that does is reduce how much your own body makes. So often you're not, unless you're taking a really big dose, achieving any net benefit. And at least for some individuals, then there's the potential downside of when, if you do stop the external source, whether your body can immediately or even eventually make up for what it wasn't doing because it was getting it externally. So I am not a big fan in general of healthy males with testosterone in normal ranges adding more either testosterone or other anabolic steroids. Yeah, so Mr. AKA says, I've been shown skepticism towards the notion of most ADHD people having RSD, rejection sensitive dysphoria, because of how common positive illusory bias is. But these two aren't mutually exclusive. No, PIB could counteract the pain of RSD. Um, so one is, part of my skepticism is that the claim again, in its most extreme form and numerous times in writing and videos, the proponents of RSD are claiming that absolutely everyone with ADHD has it. So there, I'd only have to find one counterexample. But I know I've worked with, I know in my personal life, a substantial number of people with ADHD who are not demonstrating signs of rejection sensitive dysphoria. And and again, so positive illusory bias has not been studied much, and there seemed to be an interest in it in the 90s and first decade, and almost no research since then. So it's certainly possible that these kids, but again, most of these were young kids who developed that as a defensive mechanism. But the studies and the exploration don't suggest that it's a cover up or either a conscious or, I mean, certainly not a conscious strategy. That again, these kids, and clearly there are adults like this who are just sort of impervious and things are sliding off of them. I'm not seeing details in history or details in presentation that suggests they're really in great pain and they're just hiding it or covering up. It's more, doesn't bother me. Um, so again, I think there's usefulness to the concept. The other part that I don't like about the concept is the claim that it is specific to ADHD and universal in ADHD, and a number of neurodivergent individuals, whether it's on the autism spectrum or ADHD spectrum or LGBT spectrum, and presumably others, but those are the three I know most about. A number of them display all the signs of rejection sensitive dysphoria, which I would attribute to maybe some of it's biological and their brains being different, but a lot of it is being told by society, again, either directly or indirectly. A lot of the messages and a lot of the rejection are being conveyed not just with outright criticism, but people feeling they are wrong or off or different. And the pervasiveness of that feeling, even outside of neurotypical individuals, is shown by books like the popularity of Harry Potter, that I'm really a wizard in a muggle family. And then there's countless other examples that I was really the child of aliens. There's a big theme of people feeling, I mean, I think it taps into more universal themes of each of us is unique and each of us shares a lot with other humans. And how do we reconcile those two different realms? But so Max reports that there are also some transgender individuals facing discrimination by doctors themselves, which seems especially traumatic since medical visits are some of the times one is most vulnerable. So a very good point. So as I detail in my article, even in a very liberal San Francisco, even where about a quarter of my psychiatry residency group that I trained with were gay or lesbian individuals, there was no discussion of transgender. I mean, there might have been a mention of it, which is more than there was of adult ADHD in the early 90s. But there was nothing about how to work with these individuals, how to help them, how to help sort out what's going on. Um, Hopefully, there's more now, but many doctors weren't trained with any exposure or learning, and many doctors are humans and have their own biases. So there's a horrible example that I just came across. I'm not sure the name of this doctor, but a cardiologist at a Texas hospital. So Texas, acting before the federal government in the US did anything, Texas is one of the states that passed a law forbidding any treatment of any transgender hormones or surgery. It's not clear how extensively other treatment is blocked for individuals identifying as minors as transgender. Some states have also included adults as well as minors. So a Texas doctor, he's in his 30s, he's a cardiologist, looked up patient records that these are not patients he was currently treating. He looked up their records. He did remove identifying information, but then he leaked their records to the right wing conservative Christian opponents of transgender care to publicize that the hospital that said it had shut down its transgender care was still working with some patients. It's not even clear that they were engaging in any of the specific hormonal or surgical approaches that this guy disapproved of. And he was appropriately being prosecuted because it's a crime to be looking up records when you don't have a valid medical reason to be doing that. And it's a crime to be sharing other people's information without their consent. And surprise, surprise, the case was just dropped clearly for political reasons. And worse, the doctor claims, I didn't do anything wrong, so of course this should not have been prosecuted any further. I mean, he clearly has violated Hippocratic oaths, he's violated law, and yet he's blithely unaware of and unable to even look at it. So it would be one thing if he expressed remorse about his tactics, but there is, again, not just ignorance, but there's outright antipathy in many circles. And it's been why for generations, transgender, or for generations, even LGBT, LGB, short of the T, or separate from the T, individuals have been classically reluctant to share their identities because they were treated inappropriately in a discriminatory way. Yeah, so Max is adding further that there are clear parallels to the trauma women who are seeking reproductive health care, who are faced by activists outside accusing them of being baby killers. When again, many people who are going to Planned Parenthood, I mean, a very small proportion of visits to Planned Parenthood, and I think the last statistics I saw it was less than 2%, are to get an abortion. Planned Parenthood does a whole host of, and other women's reproductive health organizations, of information, birth control, education, information about pregnancy, all sorts of things other than abortion. And yet the activists outside don't know what the life stories, what the people are going in there for, and are mistreating them. And again, that's one of the things that in the US, it's currently, many of those activists were restricted or prevented from coming too close, being too intrusive. There are laws, they have free speech rights, but the current administration has already signaled they're doing everything they can to dismantle any restrictions on such protesters. So I think there's a question and it's being, okay. So Max is sharing another comment from Reddit on the video games and ADHD video. Video games are bad for ADHD, caffeine is better. So it's interesting. Some of the comments on the YouTube station were by individuals who sort of swore by video games helping them. And I mean, clearly things like reaction time can be improved by, I mean, that's been measurably demonstrated. Actually, surgeons who did more gaming seem to be more adept at some of the newer video-based surgical techniques. And there are clearly some, anything that trains your brain can train certain skills to become better. The question is, overall, are we helping what's really important to help, or are we harming it? So there are also a host of studies showing that attention time, impulsivity, so attention time ability to concentrate for long periods of time without interruption has gone down and correlated with video gaming use. There is need for greater stimulation to keep someone's attention. There is, again, quicker response time, which means less time to stop and reconsider and halt, or so increases impulsivity have gone up. So video games probably enhance some ADHD traits and probably help strengthen some traits that need to be strengthened. And it probably matters a lot what the types of games and how you're practicing them in terms of how it's changing your brain. So I don't think video games per se should be bad. I guess part of it is that the video games, like much of modern media, are designed to hook you and keep you going. And we know, so that I do have a separate tape on video addiction. I believe that the evidence is pretty compelling that at a brain level, most of what's going on in people addicted. So addiction doesn't just mean excessive use. Excessive use is or a huge amount of time. That's part of it, but it's the time is actually interfering with other daily functions that you continue doing it despite knowing it's interfering with the rest of your life. You have attempts to quit it and have trouble doing so. You feel withdrawal symptoms if deprived of it. So excessive use isn't directly the same as addictive use, but in the individuals who show patterns of behavioral addiction, their brains also show patterns of brain addiction. So I don't think it's just a metaphor or a cute simile or comparison. I think the evidence is fairly substantial that we are really tapping into the same addictive processes, and that these companies are aware of that and design their product to maximize that. So Bob is asking a good question. Is self-medication a problem for people with ADHD, and how? So that's a philosophic question as well as a public health question. So we know substance abuse problems are abundant in America and westernized countries, other places in the world as well, but more studied here. So something like 20% of Americans over their lifetime will meet criteria for an alcohol or other substance addiction. And among those with ADHD, the rate is close. And I usually use rough statistics rather than say 37%, because so much depends upon the exact population you're looking at, the time frame you're looking at, so many details that ballpark figures I think are more meaningful. So about twice that number with ADHD, and part of it seems to be clearly the impulsivity element of discounting the future of, if I feel good now, I'm not going to worry about what this might do to my heart, my relationship, my grades, my anything else. Part of it, there's some studies that tease out probably inattentive symptoms play a role too, in terms of paying less attention to, you don't notice that the stoners are all the ones who are failing out of your classes, or so, or you don't hear the warnings the teachers giving you in the health class about the consequences of this, or you're missing on social cues, and or you're feeling socially isolated and want to be part of the cool group. So there's a host of reasons why ADHD predisposes towards substance abuse, which is one end of the spectrum of self-medication. So I'd say yes, in general, it is a more common problem for people with ADHD than the general population. And the other things that have been shown are that, and particularly kids who get stimulant treatment in childhood, and particularly early elementary, middle school years, rather than late in adolescence, children with early exposure seem to have lower rates of future substance abuse, including, and it goes down to the background rate. It doesn't eliminate it completely, but it cuts it about in half. And again, that speaks to the ADHD symptoms in and of themselves seem to contribute, separate from whether there are genetic contributions to substance abuse and ADHD, which might be in common, which clearly there are genetic factors involved in both of those. So Richard is, I think it's Richard who asked the earlier question on Broca's area. So Broca's area is the part of the brain involved in expressive language use. So as opposed to Wernicke's, which is receptive. So, and there are separate centers for sort of understanding, processing speech and for delivering and expressing it. And that was discovered by early lesion studies, damage to the brain, which showed those were separable properties. So I would think anything where you practice reading complex. No, I'm wondering now if I got that backwards, which is yeah. So Broca's is involved in expressive aphasia. So particularly not just reading, but actually reading out loud and talking complex sentences could help. So reading, I would think, if all you're doing is reading, but I mean, part of it is that reading, even some part of the process of reading probably involves at some level sort of repeating it over in a hearing yourself. So again, I would focus on talking and sharing what you've learned, not just reading silently. So Platinum has a question. So Platinum says he has a fear of something that never happened, and he creates fake scenarios in his brain and suffers from it. Is there any fix for that? My really simplistic answer is that almost anything the brain can learn, it can unlearn, but it often takes more practice or training than, I mean, since you've been practicing this is established, this is a pattern, it's going to take a lot to make it happen less often. And there's almost nothing short of overt brain damage that will eliminate it as a possibility. So my thought would be, I mean, particularly if you're not associating it with any past experience, in which case a psychodynamic exploratory, you didn't weren't abandoned by your family and wound up in some weird place, or I mean, so if there's a personal history tie-in that may be connected, then a psychodynamic exploratory looking at that approach might help. But otherwise, I would focus more on a cognitive behavioral approach than I would on medications. And a cognitive behavioral approach, and it could involve a more acceptance and commitment therapy approach. So acceptance and commitment would be when these things come up, say, okay, this is something my brain does, and none of these things existed in the past or ever did before. I don't need to worry about it. And instead, when this comes up, I'm going to think about this instead. That's sort of, and make a commitment to not getting involved, not repeating it. And that's going to take lots of interruption and stopping yourself. And again, if it's a well-practiced pathway, that's going to be hard and challenging, but there are tools out there that can help with that. So I don't know if that's helpful enough. And it's strange that I feel fairly free to give advice on psychotherapy techniques and approaches and less about specific medications. So I should reiterate right now that yes, I am a medical doctor. Yes, I'm licensed in Hawaii and California. And no, I don't have a medical relationship with any of you. I have a general informational relationship. So any recommendations I make, either medication or therapy, you should consult a local medical professional or therapeutic mental health professional who is familiar with you and familiar with whatever you're attempting to deal with. So Max asks, how do I approach the titration phase of going from finding the approximate right dosage to the more precise and minute attempt to find the perfect dosage? One is I would start by trying to refute the idea of a perfect dosage. So by that, I mean, we know that people with ADHD, we know that everyone has day-to-day fluctuations in how alert, attentive, productive, organized, excited their brain is. Almost certainly, and again, because things are hard to measure in psychology and mental health, it's hard to quantitate, but it's pretty clear people with ADHD in a completely unmedicated state have more of that day-to-day fluctuation, more, their down days are worse than the norm, and their up days are probably more productive and energetic and flying with all flags or whatever the metaphor you want to use. So given that, I mean, the perfect drug would actually adjust to whatever state your brain is that day and provide exactly what you need. So clearly, no drug is going to do that. And therefore, at least modern technology, therefore, no drug is going to be perfect. And some people with ADHD can have a pretty clear idea of if they're at one end of the extreme of negative functioning or positive functioning at the beginning of the day and can adjust their dosage accordingly. So that can happen. But part of it is, other than sleep, we don't have a good handle on what are the other factors. And sleep is a huge one, but it's not the only one for that day to day variance. So part of it, as I start right there, is it's not going to be perfect. There's going to be day to day variation. So, two different strategies. One strategy has been start a low dose, keep going up until you feel that it's working pretty well, and stop. If it's working pretty well, that's great. The other approach has been keep going up even after you feel it's great, because again, if you have ADHD, you might be missing things anyway in your self-assessment, and to keep going either until you're really clear there's no further improvement, or more often, actually, keep going until you're getting side effects that are problematic. And if you are, then drop down a notch. The potential upside of that approach is you may wind up on a higher dose that really and truly is helping you to a greater extent. The downside is that you may be on a dose that's giving you equivalent effects, and you're exposing yourself to a bigger dose of the medication, and there is limited but suggestive evidence that's not completely compelling that some of the worst side effects of the stimulants, such as cardiovascular effects and psychosis, are correlated with higher doses. So that would urge finding the least effective dose. But again, what once you're already in the ballpark of taking one of these drugs, you're probably, wherever you are in the range, at some increased risk to someone who's not. Um, so, so I'd say it's a philosophical approach as to being sad. So the other thing I would say is it's one of the areas, again, I've sort of criticized our measurements for for measurement across psychiatry, mental health, but this is one of the few cases where I do think ADHD rating scales can have some role. In terms of trying to assess, because if you just ask globally, are you feeling better than a week ago? That's pretty hard for many people, and particularly with ADHD, to answer or map out. If you fill out a rating scale once a day, that may give you a, particularly if you do it at the same time each day, some more objective answer. And I usually also encourage people to find semi-quantitative measures in your old life. So, and I pull mine from the old days. And if it took you each weekend 3 hours to get to the New York Times because you'd be distracted and jumping, and this is a hard copy version, but on your medication, you can just pick out the articles that really mean something to you and finish routinely in an hour and a half. That would be a measure of quantitative measure of improvement. Or if you start each day at work by checking your emails and you always get distracted and bogged down, and it takes you 2 hours to sort through your emails, whereas now on your Ritalin, you're getting through in an hour and answering what's appropriate and triaging the rest appropriately. That, again, each day will vary, but over a few days, you should have a pretty good idea of whether it's helping or not. So trying to get quasi-objective, quasi-quantitative methods to assess how well the drug is working is important. So, and this will probably be the last question because it's an hour in. So Bob's experience is that people with ADHD have lower confidence in themselves and the way they carry themselves compared to neurotypicals because of the shortcomings of the ADHD, forgetfulness, procrastination. So some of this is sort of feeding back into the rejection sensitivity. And I'd say, yes, I'm not questioning or doubting that may be many people or even a majority of people, but there is a marked subset of people with ADHD who are, and I'll pick on Dennis the Menace, as maybe even Pippi Longstockings. There, and we don't have to go to certain presidents where with their bluster, it's hard to know how much it's insecurity and how much they really don't care and they really have confidence in themselves and that things are going to turn out and they're just going to keep going ahead. And if bad things happens, well, lots of things happen. Doubt, self-worry, anxiety spectrum. And yes, it would be fascinating to know, is this all just differences in psychological response? Is it more positive feedback and nurturance and family or friends or schools that let people know you could be whoever you wanted to be? Or is it a biological divergence that some set of individuals are more impervious to negative feedback than others? I don't know. And I don't know anyone, I'm not even sure how I would try to study that, and I'm not sure that anyone else does right now either. But there might be, and if they do, that would be fun to bring up. So Max is pointing out that I need more current references than Dennis the Menace and Pippi Longstocking. I would argue that both of those are classics. Dennis the Menace is still running in my daily newspaper, not again that anyone reads newspapers. And point well taken. I don't know enough who in modern younger age demographics may fit. I mean, one is there's lots of people with ADHD who are talking about their ADHD online. So, but I don't know among those who may show more positive illusory bias. So thanks for being with me today. Thanks for the great questions. I'll be back next Tuesday and there'll be some new uploaded resound engineered videos this week and at least one new one. And we do again have that subreddit for maybe more detailed or in-depth or back and forth discussion of some of these topics. So have a good, stay healthy, stay happy, and I'll be back next week.